All right, ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Here with the wonderful TJ Reddington, who's the founder and CEO of the Reddington Group. TJ has done some really cool things, run some CINs and health systems, and just has a lot of experience around value. I think you call yourself an agitator for value. Is that
hopefully productive agitator?
Exactly. So, TJ, thanks for joining today.
Yeah, thanks for having me. I'll give you maybe just a paragraph of what led me to be doing this. I initially was studied engineering and graduated with a degree in that from Miami University many years ago. Got my MBA shortly after that, and decided at 24 that really I really my calling was, I think, to go to medical school. And so I quit my job, went back for a year post-baccalaureate, got into medical school, did a residency, and I think one of the great sort of nearly serendipitous things that I did was to get an MBA before I went to medical school, because I think we'll all agree that unless you have a pretty good understanding of financial flows, you're not likely to make a change that all the parties in healthcare can support.
Yep.
And so very quickly, I actually, when I got out of my residency, I joined the faculty of the University of Cincinnati and worked for a long time in what was really kind of my first population health experience. And it was looking after a lot of people who were actually didn't have insurance, but their care was supported by a tax levy in Hamilton County. And there it became incumbent on me to truthfully make the case for the continued financial support of the county and to some degree the university hospital to keep these clinics open. But we were able to coordinate the care between all these community health centers in a way that dramatically reduced their ER and hospitalization utilization, which generally hospitals want to have admissions, but if you have a huge self-pay population, you can make a financial case, let alone the humanitarian one, that you don't want to have a whole ton of people coming in for things that are avoidable. From there, I actually had the great privilege of being asked to run the Ohio Medicaid program, and I did that for 10 years. So that's obviously sort of a population health program. There's 2.5 million people on Medicaid in Ohio. And so that obviously gave me a different perspective and sort of the global population health issues. About 10 years ago, I was asked to run a clinically integrated network and start it at the Christ Hospital in Cincinnati. And the medical staff there is a pretty sophisticated group. And I think everybody understood that we needed to begin to prepare for what was going to be the new arena, which candidly, I thought fee-for-service wouldn't have been as resilient as it is. I know maybe 85 to 90% of all the transactions are still fee-for-service, and which I consider to be largely not as value sensitive as they might be. Let's say that. So with this clinically integrated network, what we did and what I think makes the most sense for most hospital systems is to learn, if you will, how to do it on the employees and their dependents that are on their own health plan. That way, it's not a terribly risky endeavor. If you obviously get into an ACO or if you go full risk in some contract, it can really have a disastrous result. But as long as everybody's careful and measured in their what they're trying to bite off, what we wanted to do was to take the medical staff to see if we could manage the expense of the health plan's expense for the hospital system. And so, and if we were successful at that, then ideally, then make it more external facing. And so that's what we did. So that's basically, so what we did over 10-year period, we started with a $43 million spend, and all these numbers have been signed off by a third party. We saved 45 to 50 million in the first 6 years.
Wow.
Um,
Wow.
and 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 the way you do that really is by you've got to identify, because typically you have 10 to 15% of the population is the really expensive group. And so the whole key to that is to be able to identify those people and engage them, and then make them less expensive. And obviously, the whole thing for me, especially, is based on how they do clinically. But you also save a lot of money doing it.
Yeah. So yeah, talk like that. That's a crazy headline to be able to save that amount of money. So obviously, data is super important. Being able to have the data to break down those demographics that are really high cost, right? How'd you kind of go about that side of it?
So there's been obviously a lot of studies about this, and it's interesting that there's a ton of data that's available to be able to do this, and you can do it based on the electronic medical record. You can ask the docs. The docs are actually surprisingly good for identifying sometimes who their expensive souls are. But one of the ways we do it, and it's for me, it's important, is I don't mean so much to sell it, although I'm interested in obviously getting this business going. But mostly as I persuade people, you don't have to, especially hospital systems. Hospital systems are loath to get another software package in there. They just, they don't want to, if they can avoid that, they don't want to do it, which I understand and agree with. So what we do is we use the electronic medical record, generally the data systems that they already have. Most of the people are running Oracle and Business Objects. And then the other thing that we use that I think is underused is what I call encounter data, which is your TPA, who's ever running the health plan. They've got a ton of data on who's who, and who's been expensive, and who, in my view, who's about to be expensive. And you can estimate that based on not only their diagnosis and their pharmacy claims, but also things that are available in the medical record and their encounter data, like their job description, stuff like that, and in particular their diagnosis and do they refill their medicines, those sort of things. And so the pharmacy claims files also become important in this predictive tool, and it identifies a group of people that what we're interested in. We try to get our arms around them, so we call them basically the high utilizers, and we get our arms around them. And mind you, it's not 100%, but it does tell us where to fish.
Yeah. And so so now you have the data. What do you do from there? How do you keep, a lot of this comes down to coordination, right? And I'd love to kind of dig into that. Yeah.
So what we'll do is we identify who our high interest people are, and obviously they're not all employees; they can be dependents. And then we generally, although not all the time, but almost all the time, they're matched up with the primary care doc who's already employed by the hospital.
Okay.
And so then we'll get a list of who their PCPs are, and then I sort of reach out to them and say, for me, it might be, TJ, here are your 30 people that we're watching, and here's why. And even me, who leads it and is financially aware, sometimes I'll be surprised by the people that are on that list. And then I'll see why maybe I didn't know that they had an expensive thing happen, or they weren't refilling their medicines the right way, or generally I'm really careful about their quality measures. But for whatever reason, it's been brought to my attention. And then what we do is we track that group, and we know that if we are able to affect the financial expense of that group, that we're going to be able to dramatically affect the financial exposure to the hospital as a whole. And so really the two things that happen out of this is that there's two really big things that happen out of this. One is the hospital saves money, and they're going to save money pretty quickly. And with half the hospital systems in the country either barely breaking even or losing money, so they get an fairly immediate payback on their investment, which is way smaller than an ACO, and it's way more nimble. And the other thing they get, though, which may be the most valuable thing, is they have a physician or a clinical staff that knows how to behave in a risk-based environment,
Mm-hmm.
which is, really an asset to develop. Your clinicians.
I have a question. Going back to, so you got your list of 30 folks that are really high, high utilizers, high spend individuals, and you said you were, surprised sometimes. How often is it something easy to fix versus how often, or percentage or whatever, versus what's the percentage of cost that's just, no, like this is just an expensive patient. They've got a lot going on and
That's
they need
a great
it.
question. You obviously can't, if someone, and I don't mean to reduce this, this suffering and bad cases to just a financial. So for some people, let's just say it's a low birth weight baby. Or and those are stuff that the insurance plans all know about, sort of the CFOs and the risk managers at the hospital. Those kids are going to be expensive, and we're certainly never in any case trying to deny anybody that they need. I mean, that would be a non-starter.
Yep.
But on balance, we're able to. Most of the people are pretty sensitive to what I would call physician engagement and case management, and by that, I don't mean just having a case manager help coordinate their care. What we find works the best is to have the physician or the physician's office call them and bring them in and say, whatever, Trudy or Marianne, we've got this stuff going on, and I'm just, and really the way I sell it to them is I just care about them, and they all, most of the time patients choose docs, and the docs don't choose the patients, so. The physicians already have established a trust and a rapport that is considerable and can be leveraged, but we have followed what happens to those case managed folks, and in our group we'd have year over year they'd still get cheaper, even though there wasn't much migration away from that group. You follow me? The people we got our arm around. Maybe 10% would leave. Obviously, some would expire, some would leave the organization, but mostly they stay there. And overwhelmingly, they got cheaper over that period of time.
And how do you go about keeping the patients completely, like the entire continuity of care under like your purview? Because that seems to me to be one of the most challenging aspects, because on the one hand, you're not allowed to dictate where someone goes for care, right? But on the flip side, if even one part of their care goes outside the loop, it makes it really difficult to keep a handle on their spend. No?
True. And so there's candidly, there's areas that we, I don't want to say haven't been as successful, but one of those is in expensive pediatric cases. We have a big, internationally known children's hospital here in Cincinnati, and so if we get an expensive kid, those are sometimes tough to adjust and own, if you will. But generally, for the adults, we've been really good at coordinating their care. Whether it's heart failure is a typically sort of resistant thing to be able to manage. But we've got, most of these hospital systems that would be, I think, that this is a no-brainer for, have already employed cardiologists and nephrologists, which are two other groups of diagnoses that can get expensive. So, generally, I think, though, that patients, certainly, they're free to go wherever they want. And if you're in Medicare and you've got folks who are going from Ohio to Florida, that's a different gig where, that if you lose them, like in an ACO, you lose them, they're outside your sphere of control. But for employees and interdependents, they're pretty much in your sphere. I would say control's an illusion generally, but generally you can own them and keep them engaged.
Interesting. And what level of care coordination or level of care coordinators do you think are necessary to make this happen? Because it would seem to me it's more about friendliness and the the reaching out than it is necessarily about the level. Like, what level of clinical training do you think is the perfect medium for low cost, high result when it comes to the actual care coordinators?
We have I don't know how many are. So we're about a 550 bed hospital. I'm not even sure how many care coordinators we have or case managers, but it's a lot. With these various Medicare initiatives, obviously, they've been rolled out and they've had, hundreds of care managers. In our population, so if we have roughly 550 bed hospital, we have roughly 7,000 employees. We have, again, obviously the number changes a lot, but say we have 13,000 people on the health plan. And we may have 1,500 people that we're managing sort of actively. And for that group of people, they'll help identify. So I'm truthfully not off the top of my head, not sure how many care managers we have that are managing just that group of people. Generally, the care managers, because they're doing so many other things, are fairly agnostic to the notion of, is this a CIN patient or is this somebody else? So just call them up. But mostly what we find to be the most effective is the doc calls them and gets them in, or the office calls them and gets them in. Because typically if you get a call from somebody who you don't know who they are, but if it's one of my patients and Dr. Reddington's office is calling, they're generally going to return that phone call.
Yep. 100%. Yeah. And then programs like transitional care management, things like that out of the hospital for everyone going out. Have you dealt with that at all?
Oh, sure. I mean, obviously there's a huge incentive for the patient, who admittedly can be tough to get in sometimes, but we generally are able to bring them in. Now, if somebody has, like, say, a complex cardiac procedure, let's say a AAA report, prepare. They may not come in right out of the gate. They may go see the vascular surgeon or the cardiologist first. But on balance, we get almost all of them in almost all the time.
Wow. Yeah. So what do you think do you think being a CIN had something to do with it? What do you think the environment for success was that you kind of set up in order to achieve that crazy number of $45 million in savings?
This is going to sound, I guess the short answer to it is will, to tell you the truth.
Sheer willpower.
Sure. Yeah. And it wasn't like you had to, knock down doors. It was, I think, initially, I think the administration was a little leery of the whole thing. And in particular, I think there were some there that were leery of sharing a nickel saved with any of the docs. Now, I'm always, I guess, sensitive to the notion that this is not a cleverly disguised plan to have physicians get paid more. But also, I think, but it's just human nature that if the docs, let's face it, they're, extraordinarily busy. There's lots vying for their attention. But you have to make it, at least you have to recognize what they've done if you save money. And so I think, obviously we saved quite a bit of money. Over the years, most of the money was saved by the hospital system. Most of the money was capped, so it wasn't distributed. We probably distributed not more than $2 million in 8 or 9 years. Wow. Of the $40 million we saved.
Wow.
So
was it saved or made? I guess. Pardon? Like I don't know. I have to think through that a little more. Yeah, when you save $45 million for a hospital, does that just mean that the hospital didn't lose another $45 million, or did they actually keep $45 million, or some part of that?
Yeah, I can show you maybe the way that it was tabulated. But the way that we followed it, and I thought that the language I chose was, I think, important because you want to make sure everybody is agreeing to the same measure of success. And so I really took it as a financial one. And the way that I chose to represent it was on a per member per month, which is what obviously the insurance companies are going to, that's the number they're going to use. And so our per member per month, believe it or not, fell over 5 years. And so it was, to my mind, even if you were hostile to the idea of this whole thing, it was incontrovertible that the hospital was saving money, and it contributed very positively to their margin.
Yeah. Well, so what do you say to the argument that, the challenge is that basically the baseline is going to continue to be pushed down by whomever, by the insurances, by the payers, where, okay, so if you tell me, last 10 years, it cost me $100,000 to care for this patient, I could do it for 70, great. But then you get that done, and now you're going to come to me and say, great, well, now I know you could do it for 70, so I want you to do it for 50. And then you're like,
right.
And then you're just constantly being pushed down to the bottom until you're just fully squeezed. And so how does that work in value?
So that's another great question. And anybody who's been in the ACO arena sort of understands this because, but what my opinion is that that after a while, you're not going to be able to save much money if you're really good at it. And so one of the things that I was able to persuade, and I think, again, it sounds like a sales job. It wasn't. It was just being rational about it, is that if we're going to manage this population, the clinically integrated network should not be, our financial incentive should be increasingly on a per member per month sort of case management fee, if you will.
Okay.
Because that's going to be the only way that we can keep on saving this money.
And that won't change no matter how much you save?
Well, I think after a while, let's just say for the purposes of argument that you've managed a population to perfection, which nobody has. But but let's just say you're reaching sort of the, if you will, the diminishing returns of managing this population. And so, initially, we saved money in chunks, and but after a while, you're going to manage it down to a certain number, and then I think that you want to change the incentive a little bit to say there's going to have to be some money thrown into the pool by the hospital system just to continue to manage these guys, because we're getting down to the end of how much money we can take out of this. Now, we'll never, truthfully, to sort of steal your battle cry, we have sort of a relentless version on a view of value. And so anything that costs a plan money, I'm looking at, and saying, is this, was this legit? I don't mean that on a transaction by transaction basis, but on, on balance, so we're looking at it all. So I think our customer, who is the hospital, knows that we were careful, and we really were vigilant about the way that the money was being spent.
Yeah. So, Dr. Reddington, let's zoom out and just talk kind of nationally, looking at the state of value-based care. It's obviously still an argument. It's still there's still two sides to the conversation. We obviously both live in the world of champions of value-based care. There's obviously another side to the argument. How do you think we're doing overall? Do you think we're moving to a point where it can be proven beyond the shadow of the doubt that this works and it actually affects the bottom line? Or do you think that maybe the system is too big to show and too fragmented to show real results? How do you think we're doing in general?
I guess I'd say I think it's going slower than I expected. I think and having been on the side of government when I was, the medical director of the Medicaid program, I think there's a tendency for some to say, oh, this is just like, for example, the first ACO rules, when they first came out, everybody was anticipating it. Everybody was excited about it. And it's like the old sort of stages of a project, when it came out, there was like unbridled enthusiasm, and it quickly dissipated and thought, this is too expensive and we don't really know how we're doing. And so I guess shorten that thought would be just to say that, as human beings, we're going to iterate our way through the solutions. And I think the way that CMS has gone about it so far is that they're admitting that there's a bunch of different solutions that are possible. But the other thing about CMS is that their solutions are primarily only for Medicare and the ACO land.
Right.
My opinion is that there's a huge untapped arena in the commercial space because the ACOs really haven't done anything there, and the employers are still buckling under the cost of this. And I think that hospitals, while they do employ a lot of physicians and other clinicians, I think truthfully they haven't taken enough advantage of their clinical staff. They haven't leveraged that. And the other thing that is a real incentive for hospitals to, I think, adopt a clinically integrated network is it's much cheaper to do it. It's much more nimble. You find out faster how you're doing because either your claims files are coming in and you can see those nearly in real time, and it contributes very positively to the bottom line. And with many people think that this system of hospitals employing physicians is broken. The business model is because their prices are rising faster than they can increase. Their costs are rising faster than they can increase their prices, and so that's why you get these gigantic systems that are. One
second. Let's double click on that. You're saying that there are those that challenge the very model of hospitals employing physicians, or do you mean outpatient practices?
No, I think just the business model of if you take Becker's and you look at some of these big systems that are losing money, like I'll say, now I know Providence over the last year may have lost $1 billion, or others, Ascension lost $1 billion. Now they're obviously fixing this, but still, if their costs are rising faster than they can raise their prices, and even some of these systems that have huge economies of scale, they're still struggling. So my opinion is that if you were a CEO, it is really a fairly low risk thing to do a clinically integrated network and just start with your employees. And then if you're a small little hospital, if you're critical access hospital, 30 beds may not make as much sense. But for the vast majority of hospitals, the 300 to 500 to say 2,000 bed sort of systems, those folks, I think it's a huge opportunity to leverage your clinical staff in ways that they haven't done already. Yeah. And the employers would be crazy about it.
That's really cool. So this kind of all speaks to your work as medical director at the CIN. Are you still doing that? Is that a present?
I'm actually going to leave that gig at the end of the month and work on this full time.
Congratulations.
So, thank you. Nice.
So tell us a little bit about the Reddington Group.
So the Reddington Group is right now me and another guy, and we're knocking on doors. That's basically where we are. I've actually, it's kind of interesting the way that you see this either be adopted or not. I've actually given presentations at the American Academy of Physician Leadership in Chicago recently, and then most recently at HFMA, and joined their faculty at HFMA. So, we're trying to essentially raise awareness about this. And as a leader of, I've been in various senior vice president roles and run big physician groups. I'm optimistic that that as the word gets out, that there's going to be more people that are interested in this, at least to hear the pitch, because if 85% of the systems are still really locked in fee for service, and they're thinking about ACOs, this is a much cheaper, faster way to do it, and I think it's much more effective. The thing I would also offer is that if you go to an ACO, and if you pull any doc out of the line, so to speak, let's say you're having a dinner meeting, and you say, hey, Dr. Smith, can you explain to me how this whole thing works? Most of them aren't going to be able to tell you because it's too complicated. And the other thing is that nobody really knows how it's going to end until they sort of reconnoiter the Medicare, the Medicare costs, and that might take 6 months or 9 months. With this, you know where you are. It's like driving a car, and
Because it's all
so
internal data.
it's all internal data. And plus, the other thing is that we update it all the time. So the docs that I'm engaging with, and occasionally the nurse practitioners, they know where they are. They know where the group is. And so the hospital leadership and we know because we meet about it once a month. So that's where we are right now. We're just starting. But I'm optimistic that I think it just makes too much sense, quite honestly.
Mm-hmm. So your vision is to come to hospital systems and pitch them on putting together a CIN?
Correct.
And then you guys will help them.
We'll set it up.
Get it set up.
Yeah, we'll take the data, right? We'll tell them what's involved. I think the other thing is that we want to make sure that it's a fit too, because some organizations, for whatever reason, like let's say, for example, if you had hypothetically a system where they said we don't want to share a nickel with the docs, that really probably wouldn't be a good fit. But just not to say that, like when I said before, when I said we distributed 2 million of the 40, the hospital kept 38 million. So it wasn't that they were able to keep, they were able to, we gave the docs some money, but the hospital kept most of it. So but I think it's important that the administration of the hospital would be willing to share some of it. Now, how much of it is really up to them and the leadership of that group. But I think most systems would be surprised at how simple this is to set up once it's been explained. Like, for example, when we were setting this up, it I think cost $600,000 or $700,000. Most of that was legal fees, and it certainly wouldn't be that expensive anymore. It's a fairly cut and dried way to go about it. And basically, what the only trick is maybe getting the analytics to analytic people to work together, which most of the time, most hospitals now are pretty savvy about that. And if you make the case and tell them who's got to get connected here if they're not already connected, then we'll have an idea of the managed population that we need to reach out to. And obviously, you want to make sure the physicians are good with it, and But I think once you explain it to them, everybody said, "Yeah, why wouldn't we do this? We're already doing it. This is just a more formal way to adopt it."
Yeah. I think unfortunately, when it comes to things like this, like a lot of it just comes down to the fact that sometimes it's just impossible for a decision to be made one way or another. Like
what?
For a decision to just be made one way or another. A lot of times.
Yeah. And, I'm sure you've heard of the John Kotter book, which was about leading change. But one of the things he says is that you have to develop you have to have a sense of urgency.
Yeah.
But for most hospital CEOs, at least for half of them, they're in a fairly urgent situation.
Yeah, I agree. Well, super fascinating. And, the nicest thing about this is, for those that are listening, once again, Dr. Reddington has actually done this, proven model with a fairly large group. So where can people find you and the Reddington Group? How can they connect with you?
Well, we've got a website, the Reddington Group, or you can shoot me an email at TJ at there's one D in Reddington, the Reddington Group .com, and we have a no cost, no obligation visit, and if you want to explore it some further, then we could make a run out there and shake a few hands and explain it to people, and if you want to do it, then we can go from there.
Awesome. And also definitely find Dr. Reddington on LinkedIn under TJ Reddington. Well, Doc, thank you so much for spending time. Really fascinating.
Well, let me ask you before we go. If you're a hospital CEO, Mendel, what would be the reasons that you would say I don't want to do this?
Well, again, based on our conversation today, I really think it'll come down to one of two things. Either I'm already too invested in a different direction, so that would be option number one, and then option number two, which I think is unfortunate, would be I just can't get, there's so many people to make this decision that I just can't get all them on the same page in the same room at the same time. And we'll schedule a meeting for, March of 25, then we'll have a follow-up in June, and then, we'll think about it in 26, and you know what I mean? So, but
Inertia.
Yeah, I'd say those would probably be the top two, reasons not to at least take the conversation very seriously.
See, I would say if I were the CEO and I had somebody come in and go, look at, if we're, let's say, for example, if you're a 500 bed hospital system, you're almost certainly spending $100 million on your health plan. And I would say, as the leader of this effort, I would say, Mr. and Mrs. CEO, if I can save you half the money that I've saved at Christ so far, we could save you $50 million in 5 years.
It's definitely a good reason to have.
Yeah, and I'd say, so that would, and unless, if you're sort of making a ton of money already, you may not be interested in this. But for many of the systems that aren't, and many of the systems that are just afraid to even dip their toe into the value arena, I really do think this is a no-brainer.
Yeah.
So I appreciate the time. Thanks Absolutely. A lot for having me.
Yeah, this was a lot of fun. Right. Excited to see the progress.
You bet. See you.
Thanks, Doc.